Today we have a very special guest, the first ever live JawCast episode, my own orthodontist, Dr. Ilya Lipkin. Doctor, thank you for taking the time after a very long day before you go off for the holidays to join me for this chat.
My pleasure, Ron.
You are one of the most experienced MSE providers on the planet.
Okay? I wouldn't call it a planet, but
when you say you're up there, though, how many cases have you done?
Over 500.
How many other doctors do you think have done 500 or more MARPE cases?
Well, Dr. Ting is one of them.
Dr. Ting is one of them, but it's probably a small group.
Probably.
So if there's anyone who can speak on this appliance and its complications, its issues, it's you. Is that fair?
Fair.
From experience.
Yeah, only from experience.
I've often said on my channel, the big issues facing the MSE appliance are failure to split adults, which is to say, so this is an appliance that goes into the roof of the mouth, and what it does is it breaks the maxilla in half, side to side. Okay, but that's only if it goes well. In a lot of cases, the maxilla is too stubborn for the small metal appliance to overcome the resistance of the maxilla. And so it's kind of, has been a little bit of a crapshoot for patients wanting to get treated. They have to deal with this uncertainty of, oh, am I going to split, or am I going to struggle and have to maybe get multiple appliances or go in for some sort of general surgery where they have to put me under general anesthesia to do the dome surgical assist.
Which is horrible.
It's a brutal procedure that involves cuts that are not unlike what they do in MMA surgery, which is something a lot of people consider to be one of the most daunting surgeries a person can do. What I want to talk to you today about is an innovation in the MSE space that has put a big dent in solving this failure to split problem. And it is the piezoelectric knife is what I've often called it. What do you call it?
Piezo.
The Piezo.
Piezo knife, Piezo tome. The Piezo tome is the proper name for it.
And what basically does it do, doctor?
It is essentially a knife that will cut through the bone and it will cut through the suture, and it will help to loosen up the connection of right and left half in the upper jaw, in the maxilla. Want to hold this for me?
Yes.
So essentially you have an upper jaw, and you know, if you look at it, you know, right here, that's the thin part. And the biggest bulk and biggest resistance to splits usually right here in the front. A lot of guys design it improperly and they put it too far back, and then there is a lot of resistance in the front. So one way to loosen up that resistance is use the Piezo knife and go right through the palate, you know, into the straight into the bone from here, and then right up the nasal spine, right from in the front, right above the front teeth. You know, right in and split that, and this way that connection is loosened up. And with the proper design and with the proper planning, the issue of splitting is no longer an issue.
Which is to say, you're seeing near perfect success rate?
I haven't failed this year yet.
Out of roughly how many cases?
Not very fair question, because it's close to an overall 150, but not all of them are adults or adult males. You know, maybe a good third of them.
And are you using this even on patients who aren't adult males, let's say? On younger patients or female patients?
My cutoff, I would say anyone over 25 will get it done. Males 25 and females around 30 plus.
So this tool has basically taken one of the biggest uncertainties with MSE treatment and eliminated it.
In my hands.
In your hands. And so is it a skill-dependent appliance? I mean, is it...
I think there's just, you know, there's a couple other things that go into it. You know, placement, the design, because as you know, I customize my own MSEs very frequently, or I order them customized. So, you know, the matter of where the TADs are placed and engaged is, I think, is critical, just as critical as Piezo.
And how do you determine that?
From a cone beam.
So every patient is different.
Every single one.
You can't generalize and say better to put it, you know, right in this spot between these two teeth, or further forward or further back.
No, it's a crapshoot.
It's unless you're actually looking at the bone of the individual patient.
That is correct. You need to look at it. You know,
Right.
if you don't use, if you know, practitioners that don't use cone beam and just guess, you know, between premolars and molars in a certain area, you know, it's a guess.
So what do you see on the scan that dictates where the appliance goes?
Where the bone is and the thickness of it.
And do you want to put the appliance sort of in the thicker area?
Yep.
Because
at
you
least
want
not necessarily the appliance itself, but sometimes you need to add more TADs, or you need to have some supports on the sides in addition to along the midline. So this way to make it properly successful, because sometimes the bone in the palate in the middle is too thin.
Right. So is the idea you want to put the appliance in the area where it gets the most bite?
Pretty much.
That way the TADs don't drag through the bone?
Yep.
Because is bone drag or screw drag, I think they call it?
Yeah, correct.
Is that the primary reason MSEs have failed? Generally?
Most of the time.
It's not that the bone is just too hard and the TAD bends and folds. It's
a combination of multiple things. I think the failures, and again, as you know, I do teach it in my course, and then I have a couple of hours on just failures alone, which I've had plenty. And I present all my failures, and then for what I've got from my own failures, anytime the screws were too far back, and without piezo, the bone is just too thin, so it starts to drag. Sometimes I hear people started to turn like 6-8 times a day. You know, this is, I think, to me is insane. And essentially what starts to happen if you put 6-8 cranks and the MSE starts to bend, the minute it starts to bend because the resistance is too great, you know, you got your TADs going this way right away, you're done. It's not going to split.
So what does turning slower, why doesn't turning slower do the same thing?
Turning slower, it gradually transfers it doesn't start bending the MSE right away. It transfers the pressure to the bone in a gradual manner. You know, kind of gradually builds it up, and then splits, rather than just, because I think once you do a lot of turns right away, it just starts to bend right away, and then once it starts to bend, it's finished. So
there's something about distributing the force over more time that is beneficial to the appliance having success.
Yeah, and Dr. Ting was actually probably the first one who's talking about slow expansion protocol. And again, in my own hands, every time I try to do more than 1 or 2, it always fails more often than not. Sometimes I had to just backtrack and start slower, and it worked second time.
So if you could give a rule of thumb for the ideal turn rate with the MSE from start to finish.
Once a day.
End of story.
End of story.
The right answer usually is an elegant one. 1 turn.
1 turn a day. Very simple.
How do you screw that up?
You can't.
Right? I want to get back into the nuts and bolts of this.
The piezo.
The piezo tome. Because it's probably scary for a patient to think, oh, am I going to have to go see a surgeon? Will they have to go see a surgeon, or is this something you do right here in the office?
I do it right here in the office. It's, you know, chair side. It's very simple. It literally is very simple. It's just like what I showed you a minute ago. You literally just numb the area and you go with piezotome. It takes, the whole procedure probably takes about 10 minutes, you know, 15 maybe with numbing and making patient comfortable. The recovery is uneventful. You know, if someone's thinking that it's a scary procedure, and I thought so initially too, until I saw a dome procedure done when the surgeon took a chisel and started whacking it into the patient's head. So, which is a lot more invasive.
Right. So you do go right through the skin. Is there any bleeding?
There's no bleeding.
Why not?
First of all, there's not a lot of blood vessels where we cut.
At the roof of the mouth.
At the roof of the mouth. But even here, somehow it probably has something to do with the ultrasonic nature of the piezotome that it doesn't bleed.
So the knife itself, it doesn't actually cut because it's sharp. Does it cut because it
vibrates?
It's a vibration.
Yeah.
Is it a heat or is it a vibration?
No, just vibration, no heat. I mean, it gets hot because of the vibration, but it's you know, there is a cooling mechanism that comes with it. So, you know, we don't want it to get hot.
Right.
But it's vibration.
Do you know why they call it a piezotome? What's the etymology of that? Do you have any idea?
It's a great question. I'll look it up.
Okay. So, but I imagine, because this is a tool that I imagine has been used elsewhere in healthcare.
Oh, absolutely.
Is it always a bone cutting tool?
It is a bone cutting tool. And I'm certainly not a pioneer in it in any fashion. I probably one of the first ones who started applying it to, you know, the MSE or, you know, skeletal expansion. But you know, Piezo has been around on the market for a good 10 plus years. It's usually used for keratotomies, SFOTs, and, you know, extractions, sinus lifts. It's been used forever.
Is it sometimes used in MMA surgery to?
I'm sure in some surgeons use it. Yeah.
Mm-hmm. I was going to ask.
But back to your question, sorry.
Yes, sure.
It's essentially, it's a procedure that in my case, in my hands, again, I do it here. But I know some practitioners who place MSCs, they would refer it to a surgeon. The only problem with that is the patient incurs a much higher cost. Now they get, they pay for the expansion, and now they also going to end up paying for the surgical fees.
Right. I imagine that's at least several $1,000s in surgical fees. You can't see an oral surgeon for less than a few $1,000s.
That's very true.
Yeah. Does the patient leave the office with a split and a diastema, or is there still a period of uncertainty after?
There is a period of, I wouldn't say uncertainty. There is a period of where pressure still has to build up and patient still has to split. Mm-hmm. Usually takes anywhere from a couple of days. I've seen it as early as 3-4 days, as late as 2 weeks. But in general, if the installation is proper, if planning was proper and execution was proper, then should be no, everybody splits.
Sure. Why don't you go all the way through? So you're saying you just score it basically?
No, you go through.
Office?
You go through.
So then if
almost all the way through.
Then what's left to resist the MSE?
Not a lot. Usually the zygomatic bones.
Mm-hmm.
Yeah, but in some, I've heard some people advocating to go under and do the cuts here. Mm-hmm. But, I don't think I'm going to be doing that anytime soon.
Mm-hmm. Does the piezoelectric surgical assist or the piezotome assist, does it help alleviate asymmetry issues at all?
I don't think asymmetry has anything to do with MSE. I think asymmetry has to do with improper installation and improper planning.
Can you elaborate on that, please?
Sure. Anytime and every time the MSE was not installed properly, there is a risk of asymmetric split. Mm-hmm. So essentially, any case that I've seen online posted or in my own hands, early beginning of using MSE, you're at the mercy of a lab, right? So even though you could now is a whole different world, but give or take a couple of years ago, when you were just, again, there wasn't. Some people used cone beams. Some people just said, put it between the premolars and the molars, but you don't really see the configuration of the palate if you're not using cone beam, right? The palate could be canted, the palate could be uneven, and if the lab installed it crooked, then and you don't see it and you don't realize it, then you're going to install it crooked and you're going to get a symmetric split.
So you're asserting that MSE asymmetry is primarily caused by an asymmetry or a crookedness in the way the appliance is put into the mouth.
Yeah, 100%.
It's not because of asymmetry and resistance that the face gives to the appliance?
That's been my experience. And I wouldn't talk to anyone else or any kind of scientific basis for this, but for what I'm seeing, and anytime I've seen failures that came through my office for second opinions or failures that have been posted online, it's pretty evident that was just installed not parallel to where it should be parallel to.
Right. Let me ask you this. In the case of a perfectly installed appliance, but no surgical assist, could it be the case that in its fight with the maxilla, the appliance gets twisted, and that could then lead to an asymmetric expansion?
If it's twisted and the bones lost resistance on one side, it's just not going to fail. No, it's not going to expand. It's going to fail.
Okay, so you don't think there's anything to that theory?
Probably not. It's just incorrect installation.
Right. Wow.
I know.
Would you? I mean, it's scary because everyone wants this appliance.
Out of 500 cases, I've had one asymmetric expansion, and when I looked at it, it's installed asymmetrically.
And so tell us more about the control that you've taken over the manufacturing of the appliance for your own patients.
For my own patients, if it's depending on the type of a patient, if it's anyone that's now it's slightly different. Up until probably a couple of months ago, I would do the entire thing myself, from start to finish, from planning to manufacturing and placing it, everything on the patient. So because I was making it myself, and I would check for parallelism, check for symmetry, pre-plan it on cone beam, measure it out, customize the appliances, and that's why it worked. Now we have some labs that could custom make it and custom plan it on cone beam in 3D, and they 3D print the some of the either they modified the existing MSCs and then they digitally plan placement, or they customize and make the whole thing custom from the screw itself to the whole framework. And that is another game changer, which becomes more and more predictable as well.
So these are like this is like a new business, a new lab that arose just to service people.
There's a couple labs, but the one I use is Partners Dental, which they have 3D digital planning and manufacturing, which is I've been very happy with. But again, you still have to check and make sure that it's all to what you still need to plan it. You can't let lab technician plan it.
Yeah. Yeah, it's scary because there's a lot of people offering this appliance, but there's very few that I would send my own brother to, for example, or that I would go to myself if I were a new patient. One way that I vet doctors that I'm referring patients to is by how many cases they have, but also simply whether or not they do the piezo tome assist, because it's a slam dunk if it's done correctly.
If it's done correctly.
What do you think about, I had someone on my channel say that he had been using, Dr. Joseph Yousefi in Seattle, in Bellevue, Washington, said that he doesn't do piezo tome for MSE because he used to do it for the mandible on his DAME procedure, distraction-assisted mandibular expansion. It's basically a skeletal midline expansion of the mandible. He said he had issues with necrosis from the piezo tome. What are your thoughts on that?
I quite honestly haven't had any yet. I think, again, there's probably a whole different ball game doing it here than on the palate.
Yeah.
I've now have a pretty big group of people who've taken the course and who are doing that on a regular basis. I'm sure that's still a possibility, but essentially it just comes down to surgical technique probably. Again, a whole different area here. There's a lot of vascularity, a lot of bleeding, a lot of areas that you could cut and potentially damage. On the palate, if you do it properly and you dress it up properly, and again,
yeah, the palate
haven't had any issues.
That's great, and that's exciting. The maxilla seems to be a pretty safe territory to mess with surgically.
Pretty safe.
It's so for a patient who's afraid, oh, I don't want some ultrasonic knife going into the roof of my mouth. Are there any blood vessels or nerves or permanent numbness or anything like that they have to be afraid of from this surgical assist?
No, not really. Not really. There's one nerve that goes, right behind the front teeth.
Yeah.
Sometimes that gets damaged, but the side effects from that is maybe occasional little numbness right around the gum area above the teeth. So it's if any, and it usually goes away as well. Sometimes patients that they have pre-existing traumas to their front teeth. They may have, after the split, and Piezo, they may get a little, like the tooth may go non-vital, and they might, require root canal, for example, or sometimes there may be a bleeding into the tooth that make the tooth look dark. So that's one of the risks, but again, it's pretty minimal in comparison to surgical risks.
Right. Since I brought up mandibular expansion before, what are your thoughts on that procedure? Do you think it's necessary? Do you think it can allow you to get more MSE expansion if you also expand the mandible?
I've never used it. Never used it. Either I've used SFOT or Vulcodontics to complement the MSE, or a lot of times, if you have lower molars that are tilted inward, you just need to upright them, and you could get a lot of expansion in the lower arch that way.
What percentage of cases would you say you just do an MSE up top, and then for the bottom you can just do dental alveolar correction?
Most of them.
Yeah, the overwhelming majority.
Yeah, overwhelming majority.
And for the cases that require a little extra, that's where you would use an SFOT. So you've never felt a need to do skeletal expansion of the mandible?
There's some potential disasters that come with that, because when you do a mandibular distraction, you twist the jaw joints.
Yeah.
So that could create other issues. And I've seen that happen in at least 3 ports. So then you have to, if you do a split here, then you have to manage the whole lower arch. It becomes very complicated.
Yeah, it's a whole order of magnitude.
Yeah.
More complication, you could say.
Very much so.
So Dr. Ting messaged me last week, and he showed me his appliance that's in his mouth.
Well, the first one I installed, he came here for Piezo. I'm sure you probably saw him posting about it.
Yes, I did. I saw him post.
And he's split. He's 59. So, and then the screw that we installed for him was faulty. So, unfortunately, so it popped a few days later.
Oh, shit.
And it started pinching him on the palate. So he removed it, and then he swapped the custom piece that he had. Now that he's split, he just installed this new type of expander. Yeah.
Do you know much about that thing?
No, not yet.
Okay.
Not yet. It looks a little bit more elegant than MSE probably. So, but at least from the look of it, it may be a little stiffer and sturdier. But as they say, I haven't tried it, so jury's still out on that.
Yeah, you know, when I saw it, my impression was that it either looked like an MSE on steroids, or that it looked like some sort of futuristic MSE.
Yeah.
No arms to the molars.
Yeah, but that sometimes carries their own issues too. So
sure. So that's not necessarily a plus. There's reasons.
It's not always a plus, right?
Interesting. What's coming down the pike for MSE treatment? Are there any new things you're working on, or are you just refining the good stuff?
Oh, just refining. Yeah, exactly. Custom stuff, custom planning, custom installation, custom design, and then it works.
Yeah, that's great, doctor.
So, and just some fine-tuning some techniques.
Mm-hmm. Hey, once you've got a winning formula, you know, there's no need to fix what's not broken.
That's very true.
I think that
you can just perfect it.
For sure. And people often ask me, they say to me, do you think I should wait before I get an MSE to see if the field matures and whatnot? And I often say, well, you can time travel by just going to a provider who is very experienced and refined in their use of the MSE, because what maturation of the MSE space means is it's not going to be a new technology. It's just going to mean that the doctors get better using the tools that are already available, and they jack up their success rates and minimize downsides and complications.
Yep, exactly right. It's all about experience, and that's all it is. It doesn't, you know, if people who've done it a lot and they know and they examine their failures, they'll know why it failed, and they try to avoid them, and they've developed better and better technique to do that.
Mm-hmm. Fantastic. Before we wrap, and we'll wrap here in a second so we can both get home, it's late. Can you just show us around? Can you bring it into the frame, please, doctor? And then
sure.
Just show us what's going on here.
So that's a Piezo knife. It has different tips.
Mm-hmm.
You could, you know, there's this one is a square. There's one rounder.
Oh, it's actually got a jagged tip that looks like like a saw blade.
Almost, but so that tip vibrates. Mm-hmm. And then, you know, then what you do is when patient is numb, you just go right in through the middle.
Yeah.
Like that, gradually, obviously not that fast. And then you go down this way.
You're holding it like a pen, so it's a delicate procedure. The tool does all the work.
That's pretty much, yes. There's no pressure. So you essentially just go just like this. Mm-hmm. And then you go above the teeth, straight into the nasal spine. So essentially releasing that where the biggest resistance to the expansion is. And after that, if your expander is installed correctly and engaging the bone where it's proper, then you should have no failures.
Stupid question, but do you do this before you put the appliance in?
Before. Yeah. So the procedure is patient gets in the chair, we numb the patient up, then I do the Piezo, then we put a dressing. Once the dressing is in, now we insert the expander, and now we put the TADs.
Wow. That's a long afternoon for that patient.
It's about an hour and a half.
Damn.
So not too long.
It gives me the heebie-jeebies just thinking about it. Have you had any freakouts? Have you ever had a patient, you know, when they're getting the sawing done, they realize what's happening and they you know.
No, they all know what to expect. We tell them in advance. They usually most of them, not all of them for that matter, tell me that it's not as scary as they thought it would be. Usually the next morning after, when I call them and to see how they're doing, usually the answer is, oh, I thought it's going to be much more painful.
Wow.
So
yeah, you've always sort of, I don't want to say minimized the pain that I experienced when I had my MSE, because I had a lot of pain. I did lots of videos about how painful it was for me. You've basically explained to me that my experience is not the norm. You know,
Right.
Not everyone has sort of traumatic pain with their surgical assist or their expansion that I had.
Usually those painful experiences came like early in the beginning. Like when I had my very first cases, and I really probably didn't know 100% what I was doing. A lot of it was some of it was guess or from whatever limited knowledge that anyone else had. Placed my first MSE 10 years ago. So
I'm sorry, you did your first MSE 10 years ago?
2012, correct.
Wow.
I read one woman's article in the magazine. It made sense, so I customized and made my own expander, just placed the TADs, because I've been placing TADs since 2007. So I just figured, what's the difference? 2 TADs in the palate.
How did you break off from the rest of the orthodontic pack and start getting into these?
I was never in the pack.
Is it because you did you do your training in Russia?
No, here. I did.
Here.
I only finished high school in Russia. Everything else was done in the U.S.
How do you go to dental school in the U.S. and not end up in the pack?
You start looking for ways to be out of the pack. You start doing something, because if you're in a rat pack, you're in a rat race, and I never wanted to be in the rat race.
Yeah, right. They say you never really get ahead in life doing what everyone else does.
That's right.
Especially in dentistry, I would say.
True.
Was it a one-off case that you did back in 2012, or like?
No, it was a young lady, 19 years old, who needed an expansion, and I felt that conventional expander wouldn't work, and I figured that's perfect case to try it.
And have you been just running strong ever since, or was there a period?
No, it was initially it was just a case here, case there. Then Richard. Richard Ting was my classmate, as you know.
Yes.
So he called me up, and we talked about skeletal expansion, and he said he was putting them on adults, like really adults, not just like 20-year-olds. And to me, it was incredible. So I said, no, I'm going to try one. So in 2015, I put it on a 40-year-old lady who was supposed to get SARPE, and she really did not want to. So I said, well, you want to try MSE? She said, yes. And I installed it. Probably didn't, she had some pain because it was, again, in retrospect, it wasn't managed quite properly, and, relied on the lab and not so much experience, but she split and worked. And, trials here and there. And then eventually, as you start, initially I used them mostly for just with the crossbite correction or getting some spaces for, crowded teeth. After a while, some patients that we used it on said, oh, I stopped snoring, breathe better, light bulb went on.
Wow. So MSE made you interested in airway, not airway made you interested in MSE?
Correct. I was always interested in airway, but it's, I was a polysomnography technician in college. So I did sleep studies for a living, but and I was aware of it for a long time, but it was never, for a long time, it wasn't a conscious effort to improve airway.
Right.
It'd be, as things started happening, then you start connecting dots. And
Super random question. I've been hearing a lot about how if you do a nasal surgery before you do an MSE, it can lead to complications from MSE. Is there truth to that? I
don't know. I had a couple of patients that had nasal surgery that didn't tell me they had nasal surgery. And one didn't have any complications. The other didn't have any complications in the beginning, but then she decided to turn it back and complications happened.
Turning back, is that ever a good idea?
Sometimes, depends on what's happening. let's say if you want to reverse something like a symmetric split or anything like that, that might be a necessity. However, in general, or it looks like there is a fistula, but in general, I don't like turning back, and especially if I tell the patient not to, and they do it against my advice.
Yeah. Patients who sort of go their own way and become their own doctor, that never works out well.
No.
Especially not when you have something as powerful as MSE in your mouth. Yeah, that's very interesting. I was going to ask you something else. Face mask. Geez, how could I almost forget? Face mask. Everyone and their mother wants face mask.
I know. People sometimes come and ask for it, even if they don't need it.
Yeah, right. So who needs it and who doesn't?
If you have upper jaw deficiency and you want to correct it with non-surgical methods, that's just one of the ways to fix it.
But we all have upper jaw deficiency, doctor.
Well, some do, some don't. I mean, from front to back, not just from right to left.
Right. So will you only treat class 3s with a face mask? Class 3,
not
for
always.
The audience, a class 3 is when the lower jaw is in front of the upper jaw, or the lower teeth are in front of the upper teeth like this.
Yeah, underbite.
An underbite.
Yeah. So that's the best case scenario for a face mask, but sometimes patients could be deficient in both jaws. So in those cases, or there is a real airway collapse, and let's say like in a teenager who is not ready for surgery.
Yeah.
So I would use a face mask there.
Would you use a face mask on an adult who was a class 1 but was clearly just underdeveloped in both jaws, or would you fear that the lower jaw you would end up with an overjet where the lower jaw didn't follow?
Yeah, I would. So, and then I had some patients who were either class 1 or even class 2 asking me for a face mask. And I would say that would not be the right choice of appliance for them. Because if we were doing surgery, then why are we doing face masks? Because that could be corrected surgically. Right. Sure. But if we're not doing surgery and we're going to create a giant overjet, then we have a problem.
All the time I have people who I speak with who they tell me, this is what my bite looks like. And then they give me a perfect class 1. But then they say, but I'm more comfortable like this. And they loosen their lower jaw, they relax it, and it slides forward into like a class 2 or sometimes even a class 3. What do you think about that? Are those patients candidates for face mask?
Maybe, maybe not. So very often when patients posture forward and they say they're more comfortable like this, that's usually indicates to me that there is some sort of an instability in the system. And when they posture forward, that's not a repeatable, stable position. Yeah. So you can't treat to that. If the patient tells me, oh, I want you to treat, I'm like this and I want you to use a face mask to match it, I would refuse, because that will create a big problem.
Is that also a sign that a patient has been watching too many videos online?
That could be the case. That certainly could be the case. But it's a position that is not repeatable. The only repeatable position is when the jaw joints sit in the socket. If the patient postures forward, that means there is some tension in the system, and by bringing the jaw forward, the muscles relax, and that makes them more comfortable. But it's not a position you could treat to.
So when we determine bite, we have to look at the joint.
That's the key.
Right. And is that done with a scan of some kind? Yeah,
cone beam, and sometimes you have to put the models in with a special bite on articulator.
Right. Interesting. Yeah, I always tell patients, they always when they're chatting with me, they say, no, this is where I want to bite. And they go like that. And I say, smile. And then they smile. And the lower jaw goes right back.
Exactly.
I go, that's not a sustainable position for your lower jaw.
For someone who's not a dentist, you're very educated. I think you should get an honorary degree.
Doctor, that's extraordinarily kind of you to say, given my trauma with having not gone to dental school, even though I really wanted to. So that means a lot.
Never too late.
Well, we'll see. But for now, I do have warrior knowledge, which is to say, I've been through it.
Yeah, you have. You certainly have.
There were multiple years where I thought my lower jaw belonged 8 millimeters jutted forward, until I realized, after some treatment where my upper teeth went forward, that my lower jaw was not following, and I ended up looking like a beaver, Yeah. And that was a very rough lesson.
I've seen all those pictures.
Yes. Of me?
AGGA and all. Yes.
Oh, yeah. I've seen that happen to several other people where they'll say, "Oh yeah, I'm in AGGA right now," and they'll smile, and I'll say, "Ooh,
Yeah,
ooh."
exactly.
Right?
I've seen a couple of those.
Yeah. Which face mask do you use? The crane, the bow, the regular old, the Grumman's?
I use a conventional face mask that, it's just straight over the face, a pad here and pad in the chin. For someone who's got TMJ problems, probably a crane is a better choice, but it's very cumbersome. I find it. I've tried. I have one patient who decided to try it himself.
Yeah.
Again, no objections to it at all. It's makes a lot of sense.
Mm-hmm.
It's just very cumbersome. But there's another one that I've seen, but I haven't tried. The one that gets attached to the head and kind of sits in the front.
Oh, I haven't seen that.
Yeah, I've seen that, but at least just like prototypes, but not. I don't think they have actual manufactured it. But for now, most patients just a conventional face mask. Grumman's, I think, has pads on here.
Correct.
Which is not a good idea because your whole mid face comes forward with the face mask. So if you have a padding on the on here on this bone, zygomatic bone, then you restricting. It's like trying to pull yourself out of, water by pulling yourself by the hair.
Right. It's canceling itself out. Basically.
Right, it's canceling itself out, exactly.
Wow, that's incredibly ignorant of the manufacturer of that appliance then.
Look, sometimes it maybe work for some younger kids, but someone try to think of something to rest it here, maybe not so much on the chin, so that in some patients that could be an alternative, maybe not the best one.
Right, or in all fairness to them, maybe they just didn't realize that pulling on the maxilla could have the effect of pulling on the entire face.
Yeah.
It's kind of a new idea.
Yeah, no, every time we see, protraction cases and superimposed protraction cases, the whole mid face comes forward. That's why patients who get MSE with face mask, develop better cheekbones.
Right. So you admit that MSE can and often does have an effect on the cheekbones, a positive effect.
Always, yeah.
Yeah, okay. How do you manage when the patient is wearing the face mask that pushes on the lower jaw like that? What do you tell the patient? If there's pain, stop? Do you tell them to consciously engage and push back against it, or
no,
just plug and chug?
Just plug and chug, exactly. And if they do have pain or discomfort, then we look for alternatives.
Right.
Or if they have the TMJ issues.
Right. And what's the ideal angle to pull on a face mask? Let's say the maxilla is parallel to the earth, which it never really is. I feel like in most patients it's downswung.
True.
How do you like to pull? Do you like to pull flat, parallel to the earth? Do you like to pull it
slightly down?
Excuse me?
Slightly down. Slightly at the down angle.
Slightly down?
Yeah.
Why is that?
Well, you have to realize that if you're dealing with the class 3 cases, especially if they have upper jaw that's deficient and they're kind of, a lower jaw is like a swing, right? So it auto rotates forward, and that's where your class 3 comes from. So you want to pull the upper jaw down and forward. So this way, that's how natural growth would happen. So it pushes the bottom jaw kind of down and back a little bit, and that's part of your underbite correction in non-surgical cases.
Oh, wow. So part of correcting the underbite is actually, to some degree, moving the lower jaw back a hair.
Correct.
Okay.
More down than back, but by virtue of it moving down, it's if you plot horizontal points, it kind of goes like this. So it has a back motion, even though you're not really retracting the lower jaw.
Right. Wow. Gosh, any kid who wants MSE and face mask, they want to pull straight up to 12 o'clock, doctor. You're shattering a lot of dreams right now.
Well, if you're going to pull up, then you're going to work a lot more against a lot of other, there's a lot of resistance up. And then that's one. And second of all, most class 3 patients, with the very few exceptions, are deficient in vertical. So why would you want to make it more deficient if you want to pull up?
Right. Yeah, they are deficient in the vertical, aren't they? It seems almost like it's like a shortness of this whole space.
Yeah, that is correct. So you don't want to make it even shorter.
Right. For the non-class 3 patients who are just universally small everywhere, but in a class 1, would you say it's reasonable for them to sort of pull straight?
Straight or slightly down still.
Interesting. Because if you pull too far up, you're just not going to get any results.
Right. Exactly.
You're trying to compress bone into bone, basically. At that
That is correct.
Interesting. Doctor, you've given us lots of information, some of it counterintuitive, but all of it I trust to be true and correct. So thank you so much.
My pleasure, Ron.
I'll let you go now. Really, I'll let you go this time to your family. Merry Christmas, Happy Hanukkah, Happy Holidays.
Thank you. Same to you.
Enjoy your travels tomorrow and your time off this week.
Thank you.
Okay, thank you so much, Doctor.
My pleasure.
All right, bye-bye.